autumn 2022, so we're looking at probably 4 to 6 weeks away, and therefore if you are interested in the WAXscope, please do email info@clearwax.co.uk and we can add you to our mailing list. This is a patient who attended with bilateral, fully occluding, very soft glutinous earwax. This is probably the most difficult type of earwax to remove because it's very sticky and mushy. It can easily clog up the suction tube, and it also adheres itself very tightly against the ear canal walls. Quite often with glutinous wax like this, there's a high concentration of dead skin and also an oily sweat secreted by the ceremonous glands. And to help, I've just installed some olive oil spray. This will help lubricate the inside of the suction probe, and it also helps change the consistency of the sticky glutinous mushy wax. And I'm using the 4.25mm speculum. I suspect this is going to be the most commonly used speculum with the WAXscope, and we do have a smaller size, a 3.5. In fact, I used that the 3.5 today on a child, a 3-year-old child who had pushed a piece of polystyrene very deep in the ear, up against the eardrum. I'll try and upload that to a video tomorrow. We've also got a larger speculum, 5mm, and then an extra large, which is a 5.75mm, which will probably be used for muscle cavities. You can see how I'm working this wax and dead skin and just trying to separate it from the ear canal wall. So we're just at the base of the ear canal here. You can see it's just blocked the suction probe. I'm just trying to wriggle that suction tube to unlock it. So what are the benefits of the WAXscope? So the WAXscope was developed, the idea behind the WAXscope originates 4 or 5 years ago. I think in 2017. And the reason for the WAXscope, if you've been following me already, you know that we've already got our flagship product, the Occluding, and that's a wireless endoscope. In terms of the view offered by an endoscope, it's just unmatched, it's unparalleled. The field of view, it's stunning, and if you follow my other YouTube channel, the Wax Whisperer or Hair Clinic, you'll see more than 1,000 on videos using the microscope. But it is a bit more challenging to use the endoscope in terms of, especially in narrow twisty ears, and that's until you've got the skill level. So once you've acquired that skill level, there's nothing better. But it's fair to say that during the last 5 or 6 years of training people, that not everyone is able to use the endoscope. So with the endoscope, you hold the endoscope in your non-dominant hand, and you not only use the endoscope to visualize the earwax, but you also use the endoscope to stretch and widen the ear canal to allow you to insert instrument into the ear. So it requires a high level of bilateral integration and coordination. Now with the WAXscope, we incorporate a speculum attachment. So the WAXscope works much more like an ENT microscope. I'll just come back to that. So this wax was a lot deeper in the ear, so we just released it. It was near the eardrum. I'm just going to go back in, just a bit left there. And you can see the eardrum in the distance. So we're going to adjust the focus in a minute, so you'll see the eardrum in full view. But you can just see how clear this view is with the WAXscope. So it mimics a microscope view. So similar to a microscope, you can see I've just adjusted the focus there. You can see the blood vessels and capillaries. It's just a bit of soft wax on the anterior canal wall. I went in with the sucker, just hovered it over it, managed to get a little bit, but I just left the rest because it's not going to affect the patient anyway, and we don't want to graze and cause any trauma to the ear canal. So you can see I've just gone in with the sucker. I'm just going to hover over it. If it came out in a big chunk, brilliant. If not, I'm just going to leave that. So patient's left ear is treated. We're going to do the right in a moment. You can just see how magnified it. This is how it looks with a microscope. So it's a stunning view. It's very focused and enlarged and clear. So when you perform microsuction with using an ENT microscope or probably less adequate loops, because loops you can never get the same level of magnification with loops compared to a microscope. So it's a microscope's far superior than the head loops that a lot of people use, in the UK at least. You use a speculum, and more specifically, there are many different types of speculum, but a share or a rosen or Tamarkin speculum. And these speculums, they're designed to enter the ear up to the juncture of the bony and cartilage portion, so probably about a centimetre into the ear canal. So we want to avoid contact with the bony part of the ear canal. And it's the outer third of the ear canal, the cartilaginous portion, that's malleable and flexible. So you put the speculum in, and if it's a narrow, bendy, twisty ear, you can position the speculum to straighten the ear to visualise down towards the eardrum. Because past the second bend, the ear canal becomes a lot straighter. It might go up and down, but it's generally in a straight orientation. And with the share, the rose and the Tamarkin speculum, the proximal end, so the end that you hold, it flares out, and that stops and prevents the speculum from going further in inadvertently. And similar to the WAXscope, we've designed the speculum so it's you've got the tip portion, which more or less resembles the share or rosen or Tamarkin speculum, and so you can't over push it into the ear, in other words. So you don't have to worry about causing any trauma. I'll just come back to that in a moment. So again, this is the patient's writing. Now this ear, the wax is even more stickier and glutinous. I have to put a lot more drops in. It's a lot more stubborn here. And you can tell by the colour, it is a lot darker on this side. So I've just gone to the front part of the ear canal. It's very sticky and adhesive. I'm just going to loosen this. You'll see this come out in a moment. So yeah, so with the WAXscope specula, they are uniquely designed, but the tip of it kind of almost resembles what's normally used. Then you've got an extension to the speculum, and that extension is the bit that attaches itself to the WAXscope itself. So it's single-use, disposable specula. There's no chance of cross-contamination between patients because the way the specula is designed, the instrument only goes to the specula. It doesn't make contact. There's no mounting system per se, so it's not going to you're not going to transfer wax infection from one patient to the other inadvertently. So we've cleared the blockage, but I'm just trying to see, this is really sticky and glutinous, so I'm just hovering over. If it comes out, brilliant. If not, I'm not overly concerned. There's a bit of wax at the roof here, so we want to get this out because that's probably a bit of a significant amount of wax. And you can see with the speculum, we've got at the roof about 1 o'clock. There's a slit there, and that helps with the insertion of the instrument. So not only does it allow you more manipulation of the instrument, but it doesn't obscure the view in any way because it's coming from a high angle. So just getting the eardrum in focus here. You can see the capillaries there, just adjusting the focus, swipe with the finger. Again, I'm just gonna hover over, see if we can get a bit more out here. So the benefits of the WAXscope is that it's a lot more user-friendly. Yes, the view, it's like a microscope, but it's not an endoscope, and let's be clear with that. So personally, I think that the endoscope is in a league of its own. If you're not able to use the endoscope, then the WAXscope, in my opinion at least, and of course I'm a bit biased because I developed it, but we didn't develop this by accident. There was a lot of thought process. It's taken me 5-6 years to develop. I feel that the WAXscope is the very next best alternative to the endoscope, if you're not able to use the endoscope. So there's some of the remnants, mainly from the patient's left ear, the first ear, the right ear. A lot of it got suctioned up. There was a lot